Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Financial Insolvency as a Risk Factor for Early Mortality Among Patients with Cancer by Scott D. Ramsey et al. My name is Yusuf Zafar, and I'm an Associate Professor of Medicine and Public Policy at the Duke Cancer Institute in Durham, North Carolina. My oncologic specialty is gastrointestinal medical oncology. Almost daily, reports in the lay news document how Americans are struggling with medical bills. The reports detail case after case of insured patients, many with cancer, who are forced to make drastic lifestyle changes to make ends meet and pay off their bills. Over the past few years, a growing body of evidence has supported these reports, with numerous studies in the cancer literature describing what has been called the financial toxicity of cancer care. Not unlike other cancer treatment-related side effects, the degree of financial toxicity can range from subjective distress resulting from monthly copayments that prompt changes in household spending, all the way to personal bankruptcy. The scale of the problem is overwhelming. The Centers for Disease Control and Prevention has reported that 1 in 3 Americans experience financial burden as a result of medical care. The problem is likely more pronounced for patients with cancer. For example, studies suggest that 50% of Medicare beneficiaries with cancer pay at least 10% of their income towards cancer treatment-related out-of-pocket costs. In other words, half of all elderly cancer patients are defined as having insufficient health insurance coverage, also known as being underinsured. Over the past few years, multiple studies have described the cancer patient experience in regards to financial toxicity. Due to high out-of-pocket treatment-related costs, insured patients have cut out vacations, reduced spending on food and groceries, sold property, worked longer hours, and, in the most extreme cases, declared personal bankruptcy. In 2013, Ramsey and colleagues published an important study in the journal Health Affairs that documented the risk of bankruptcy associated with cancer diagnosis. Using a novel merger of Washington State bankruptcy court data and population-based surveillance epidemiology and end results, also known as SEER, cancer registry data, the investigators found that having a cancer diagnosis was associated with a more than doubling of the likelihood of declaring personal bankruptcy. This finding spurred many questions, one of the most important of which is, do patients who experience extreme financial distress also have worse outcomes? In the article that accompanies this podcast, the same group of investigators published a study in JCO that attempts to answer that question. Using the same methodology from their prior study, the investigators linked SEER cancer registry records and federal bankruptcy records for Western Washington State and identified patients who were diagnosed with cancer from 1995 to 2009. They used a statistical method called propensity score matching to account for differences between patients who filed for bankruptcy and those who did not. Matched characteristics included age, gender, race, marital status, residence type, income, stage of diagnosis, and cancer treatment. The key finding from this study was that compared to cancer patients who do not declare bankruptcy, cancer patients who declare bankruptcy were at 75% greater risk of mortality. This is one of the first studies to demonstrate a relationship between financial toxicity and patient outcomes, specifically survival. So what does this mean for patient care? It means that oncologists should acknowledge and address the potential financial harm of treatment in the same way we address the potential physical harm. Before starting patients on chemotherapy, we go to great pains to describe the side effects of treatment. I always tell patients about to start therapy with an anti-VEGF agent that they have a 2% risk of experiencing a cardiovascular event. But rarely do I tell them that they may have a much greater risk of receiving a large bill in the mail as a result of the drug. Importantly, having a cost discussion once is probably not enough. For my patients on platinum drugs, I will frequently evaluate the presence and severity of their drug-related neurotoxicity. Shouldn't I do the same for their drug-related financial toxicity? These study results suggest that when considering the value of care, cost must be a part of that discussion. Traditionally, we have seen value in cancer care defined primarily in terms of improved survival in relation to physical side effects. But with growing cost sharing on the part of insurers, burdensome out-of-pocket costs related to care are almost inevitable. For many patients, these costs must be considered as a part of treatment decision-making. So what are the next steps in terms of research in this field? I think a compelling, unanswered question remains, and that is, why does extreme financial distress increase the risk of mortality? There are at least 3 potential mediators in the relationship between financial distress and worse outcomes: financial well-being, health-related quality of life, and adherence. All 3 factors are impacted by high out-of-pocket costs. The most important in regards to worse outcomes is probably adherence. Studies have shown that high monthly copayments for anti-cancer drugs can induce non-adherence to those drugs. Actually, the copayments don't have to be very high at all. One study by Stacy Duzatina, also published in JCO in 2013, found that among patients with CML, copayments higher than about $53 a month for imatinib resulted in a 70% greater risk of non-adherence to imatinib. Research should focus on, first, describing why financial distress harms outcomes, and second, intervening on financial toxicity. Of course, policy interventions are key to reducing costs and improving insurance coverage. But until those policy interventions are implemented, research should focus on interventions at the level of the patient and provider. These interventions might promote education around costs for both oncologists and patients. Interventions could improve communication between patient and provider regarding costs of care. And interventions could seek to link patients to financial resources to help pay for care before incurring insurmountable medical debt. The study by Ramsey and colleagues suggests that extreme financial distress, as manifested by personal bankruptcy, might be associated with earlier mortality in cancer patients. Long-term solutions have to focus on policy shifts involving how we set prices for drugs and how we design health insurance. But for more immediate solutions, interventions have to focus on the oncologist and patient. To reduce financial toxicity, it's time to intervene. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.